Morning, guys. Welcome. Hello. Good morning. Welcome back. Hi, Megan. Didn't see you guys last week, unfortunately, but I feel like it was literally yesterday when we last had class. I don't know about you, but I feel like it's coming around so quickly at the moment. All right, come on in. So, exams. I hope you all went well. I hope it was all good. You should be getting your marks back pretty soon. So, yeah, they aren't released yet because we've had to go through and hand mark the movement analysis. So that's why it's not like an immediate release like it sometimes would be with an online exam because of that movement analysis. Hi, guys. Angie, nice to see you all. So what tends to happen after, I guess, that mid-semester exam and also, with StuVac coming up, there is a bit of a drop in engagement. I know we're sort of getting to the end and you all want that next week off, which is StuVac. So we got one more class to get through before then. So I had technology issues in the previous class where I would share my screen, you guys would disappear and I could no longer see you. So I'm gonna troubleshoot that now. So if you see some things pop up and pop down, don't worry, but I'll just keep talking whilst I'm doing it. Yeah, so last week, oh yeah, I figured it out. Okay, good. So awesome. Hi guys, welcome. So last week was that little online video that I made about the what was it about? The complex movement analysis. So the first one about the soccer kick. So if you had a chance to watch that, that's great. If not, we're not going to actually do a complex movement analysis today. We're going to wait till after StuVac to firstly do them. So it's no issue if you haven't watched that yet. Today, we are doing the pelvis, the hip, and the knee. And to do this week, Lee's actually, he put up a lecture, but it's not like a normal lecture. I guess that lecture was more of like a bit of an intro to this class. It was only 15 minutes or so. So just so I've got an idea of who or how many of us have watched that lecture, can you guys do thumbs up or thumbs down if you haven't watched it yet? Most? All right, awesome. So most have, a couple who haven't, that's fine. Just watch it soon after doing this tutorial. We'll still go through everything, so it'll all make sense. But for that deeper level of understanding, go back and watch that lecture after today. Okay, so we're going to do our little quiz to start off with. So you can bring up that Mentee screen in the background again, and we're going to do a little revision. So you'll remember last week, what did we do? Oh, we did that video the week before that. Oh, it's been so long since we've been in class. I literally feel like it was yesterday though. But the week before that, we did the elbow, the wrist, and the hand. So some of the things that we looked at were like the angulation of the elbow. We saw that the elbow complex is actually 3 joints that make up this complex of the elbow. We spoke about some of the different ligaments at the wrist, also the different types of prehension. So remember, prehension was grabbing. So that's what we're going to have a couple questions on that in this little pre-class quiz, and perhaps a question or two to prepare us today for the hip and knee. So thanks to those of you who've chucked cameras on. It's lovely to see your faces. And this class, I'm going to a bit more interactive than the other couple of classes. They haven't been as interactive, but we're going to try and do that today. So if you can at home, chuck your camera on, and then we can play around, do thumbs up, thumbs down and stuff like that, and have some good interaction and feedback and make the class maybe more fun. So all right, 24, 20. Okay, let's get into this little pre-class quiz. So remember, just have a guess. Doesn't matter if you get it wrong. It's anonymous anyway. So first question is, what type of prehension is used when holding a tennis racket? Is it power or precision? So these were the two main classes of prehension that we spoke about last fortnight. What did we put? Oh, good. Okay, good. It's power. So remember, power was thumb adducted and precision was thumb abducted. So power would be holding that tennis racket. We're going to want to hold onto it with a lot of force, a lot of power to hit that tennis racket back and forth, right? So the thumb is the key for telling between those two there. All right, next question. Normal range of elbow angulation. So we've got a couple different options here. Firstly, we need to figure out, is it valgus or varus? So remember, the valgus with the L in it means the distal end is more lateral, whereas varus means the distal end is more medial. So what did we put? Oh, very good. 10 to 15 degrees of valgus. Good job to those of you who've got that one. So remember, the elbow, or the sort of shoots up laterally from the humerus because of the shape of the trochlea. So remember, the hourglass shape of the trochlea means that the forearm shoots out laterally. So remember, valgus, L for lateral, and it was 10 to 15 degrees. Okay, next question. Name of the joint between the capitulum of the humerus and the head of the radius. So here are the three joints of the elbow complex: the humero-ulnar, the humeroradial, and the proximal radio-ulnar. Which one are we referring to here? Okay, awesome. It is the humeroradial. So whilst we were given a lot of detail in that question, you know, we were told the capitulum of the humerus and the head of the radius. We didn't actually need to know that at all. We just needed to see humerus and radius, put those together, voila, you've got humeroradial, right? So good job. Question number 4 now. What is the name of the socket that articulates with the femur to form the hip joint? Talking about this guy right here, what was his name? Yes, it is the acetabulum. Good job. So remember, the glenoid fossa is the equivalent, but in the shoulder at the glenohumeral joint. But it is the acetabulum at the hip. Okay. Then one more, is that it? One more question. So out of 5 today. What is the correct term for lateral flexion of the wrist towards the midline from anatomical position? So we're given quite a bit of information here. What are we thinking? All right, a few different answers. There's actually 2 correct answers for this question. So lateral flexion means like side to side, right? When you read that, you might have thought lateral flexion, well, lateral is away from the body, right? So why does this say lateral flexion towards the midline? Well, at the wrist, whether it's towards or away from the midline, this is called lateral flexion. It's a general term, right? It's the same as our trunk. This is lateral flexion. It doesn't mean if I'm going one way or the other. So lateral flexion towards the midline will be coming in like this. So imagine my arms out straight here, so anatomical position, but coming in like this. Remember, coming towards the ulnar on the pinky side of the hand, ulnar deviation. And that's also called adduction. Good job. And then radial deviation would be towards the radius. So going like that towards the radius. And that's also known as abduction as well.
Clem, really quickly, in an exam, would you take either answer if this was a question?
Yes. Yeah. I would probably always call it ulnar deviation, radial deviation, just because it's a bit easier. Like you can actually just look at the bones and tell which one it is. whether you're in anatomical position or not, radial and ulnar deviation always works. I guess it's a easier one to see, but you definitely get whichever one you want to use is totally fine.
Thank you.
No worries. So give yourself a mark out of 5 there. Hopefully you all did good. You actually did do very well in this quiz, so give yourself a little pat on the back. Now, today we're going to follow on from Lee's little pre-lecture and talk about the hip, then we're going to move down to the knee. So we've done the upper body now, we're moving down to the lower body, and again we're going to work proximal to distal, so from the hip down the limb. So firstly, we need to look at our coxal bone. So we know the coxal bone has actually got 3 parts. And when we're babies, when we're born, it's actually 3 individual bones that fuse over time. So we've got the ilium at the top, the ischium at the back, and the pubis at the front. We will continue using the Mentimeter throughout this class. So if you want to keep that up, that would be a good idea, because we're going to refer back to that in just a moment. So 3 parts of the coxal bone. Then we have the socket where the hip sits. So this is the acetabulum, and the head of the femur sits in the acetabulum to create our hip joint. And we know that the hip is a ball and socket joint, so it's multi-axial. We can get lots of different movements happening at our hip. The other ball and socket joint we've already looked at this semester is the glenohumeral joint up at our shoulder. Now, something that we're going to be talking about a lot today is the trade-off between stability and mobility. So stability versus mobility. That's something that's going to continue to sort of pop up today. And what I mean by that is that it's really a trade-off. Now, when we have a joint that's very stable, generally that means that it's not very mobile, right? So a more stable joint is less mobile. It doesn't have as much range. Whereas a more mobile joint is not as stable. It's at more risk of dislocation, right? So if we think about our 2 ball and sockets, the hip and the glenohumeral joint, which one of those is more stable? So I'm going to get you guys to do like 1 or 2, like to the camera. So if you can check the cameras on, but give me a 1 if you think the hip joint is more stable. Give me a 2 if you think the glenohumeral joint is more stable. Yeah, awesome. It is that 1, right? The hip joint is a more stable joint because it's got those 2 bones really sort of encapsulating each other. It's got that deep acetabulum, and the head of the femur is right in there, so it's very stable. But what that means is that the hip joint might lack in mobility. So whilst the hip joint is more stable, the glenohumeral joint is more mobile because it doesn't have as much bone sort of covering it. That means it can move a lot more through different ranges of motion compared to the hip. Now, there's a few structures as well at the hip joint that we need to talk about. So Lee mentioned these in the lecture, so we're going to go over them now. But the first one is the acetabulum labrum. Now, we also have a labrum at the glenohumeral joint, so we're now having one at the hip, the acetabulum labrum. And it's the same thing. It's the fibrocartilage rim that runs around the acetabulum, that suctions in the head of the femur. And even though this is a stable joint already, that really contributes to stability. It's like a vacuum seal on the head of the femur, right? And you might have seen this video before. I did put it on my Instagram page. So you can see here, this is a cadaver, right? So we've got a coxal bone and a femur. And what these people are doing is they're taking the femur and they're putting it into the acetabulum. And when they put it into the acetabulum, you'll see the labrum sort of pop and vacuum seal the head of the femur in. So we'll be able to see the labrum and how the vacuum seal works. And then as the person tries to pull the head of the femur out, it's really stuck in there. They can't pull it out. It takes a lot of force to pull that out. So let's have a look here at how the acetabulum actually works in motion. It's not a very pretty video, but here, okay, look at the start again. So he puts it in, and then there's the labrum, creates that vacuum seal now. So you can see it's sort of sticking out there. There's our fibrocartilage labrum. And then as he tries to pull it out, look at how much it sucks on. Yuck, right? So it very much contributes to the stability of that joint, provides like a vacuum seal. So that's the labrum. The next feature that we want to talk about is transverse acetabular ligament. Now, if we look at our hip joint, you can see clearly that the acetabulum, it's not a full circle. There's a drop off right here. You see that? It sort of cuts away on the inferior part. And you can see that clearly in the picture in your lab book as well, that it doesn't actually create a full circle. It's so close, but then it's like cut out here. Now the transverse acetabular ligament crosses that bridge inferiorly and helps to provide stability to that joint and prevent inferior dislocation of the femur. So it finishes off the circle on the inferior part and prevents the femur from dropping downwards. I've had a look in the video, but I can't manage to see the transverse acetabular ligament in this video. So so let's have a look now at the third important landmark at the hip, and that is the ligamentum teres. Now this ligament runs from the head of the femur into the hip joint, and you can see it very clearly when they pull out this femur from the socket. So have a look here as I pull out the femur. Oh, look, there it is. Yuck, right? There it is inside the joint. And it actually runs from, you might have noticed this, that on the head of the femur, there's a depression. So see how there's a hole on the head of the femur, that circle? That's called the fovea, and that's where the ligamentum teres comes from and then inserts into the acetabulum of the hip. You don't need to know that that's called a fovea, but you might, in case it's interesting to you, it's a new landmark. So ligamentum teres, it's an interesting ligament. Historically, they don't know what the function is. They think it's probably got no real function at the hip joint. There are some arteries that run through it, and it perhaps plays a little role in stability, but generally it's thought that there's no function to this ligament. And I used to work with a girl called Annie. She was in the Australian Ballet, and she had a hip injury. I can't remember what it was exactly. And she went and got an MRI on her hip, and the injury was completely unrelated, but they go, oh, and just so you know, you don't have ligamentum teres. And she was like, what? Like, I didn't know that. And they're like, yeah, you don't have this ligament. And they assume that perhaps through the wear and tear of being, you know, in the professional ballet with all of the rotation and things that they have to do at the hip joint, that perhaps this ligament has just worn away and she hasn't even noticed. So that might, you know, also help support that argument of that it's got no real function, because she didn't have hers and she didn't even know it until, you know, she had an unrelated scan and they found out that she didn't have it. So it's an interesting little ligament in there. Okay, so these two new ligaments that we're looking at today, I mean, the transverse acetabular ligament and the ligamentum teres, these are inside the hip joint. So I guess these are intracapsular ligaments of the hip. But we've also got our extracapsular ligaments of the hip, which we know from structural anatomy. Remember these ones? We have the iliofemoral ligament, so coming down from the ilium to the femur, the strongest ligament in the body, this one, iliofemoral. We have the pubofemoral ligament coming from the pubis to the femur. And then on the back, we have the ischiofemoral ligament, like a spiral running back on the posterior side of this joint. So all these three ligaments wrap around the hip joint, and as we move our hip through different actions, these ligaments actually tighten and loosen at different points. And it's quite interesting. You can do a little experiment on yourself. I'll show you how it works. You'll have to excuse me because I'm wearing tracksuit pants, but you know, this is what life's like now. So here we have hip flexion, which is coming up forwards, right? Flexing the hip, coming forwards, extending the hip, coming back down, 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 and then I pass the midline to hyperextension, right? Then we have abduction of the hip, taking it away from the midline, and adduction of the hip, adding to the midline. Now the hip also medially and laterally rotates, and that's easy to see if I sort of bend my leg up. So if I flex my hip, medial rotation of the hip is actually, think about it like medial rotation of the femur. So take the femur, rotate it inwards. That's medial rotation of the hip joint. Take the femur, rotate it outwards. That's lateral rotation of the hip joint. So medial rotation, lateral rotation. Medial, lateral, medial, lateral. And when I'm in this flexed position here, it's very easy for me to medially and laterally rotate the hip joint because the ligaments that run around the hip are loose in flexion. Whereas if I put my hip into extension now, or hyperextension, and I try to medially and laterally rotate the hip joint, it becomes very hard. I feel like my hip has become like, you know, super tight and I can't move it as well. So when you're in this hyperextended position, the ligaments of the hip tighten and wrap around the head of the femur and sort of contribute to not really stability, but because they're tightened, you can't move the joint as much. So in that position, they're very tight and limit rotation. You can try it for yourself sometime at home. It's interesting. Okay, let's move on now. So we have some different angles at the hip that Lee spoke about in the lecture, and we're going to talk about them today now as well. If you give me 1 second, I'm going to turn off the heater because it's really hot in this room. Okay, much better. All right, so angles of the knee. Oh, not the knee, the hip. So we've got 4 different angles that we want to look at today. The first 2 in that table are the center edge angle and the acetabular anteversion angle. Now these 2 relate to the alignment of the acetabulum. So write that down somewhere. The first 2 relate to the alignment of the acetabulum. And then the next 2, the angle of inclination and the torsion angle, refer to the alignment of the femur. So that's important to distinguish between, just to help you learn those a bit better, because there's a lot of angles here, right? So first one is the center edge angle. Now the normal angle for this is 35 to 40 degrees. It's also called the angle of Weiberg. And this refers to how much coverage the acetabulum provides the femoral head in the frontal plane. So this image is from the frontal plane looking straight on at the femur and the acetabulum, and we're looking at how much coverage there is at the superior part of the acetabulum. So there's actually 2 angles on that picture. Make sure you highlight the one that says 35. The one that says 125 is referring to something else, right? So we're only looking at that one that says 35. Now, if that angle was greater, there would be more coverage of the acetabulum on the femur. If that angle was smaller, there would be less coverage of the acetabulum on the femur. So a greater angle would mean more coverage, a lesser angle would mean less coverage, right? If you think of my hand as the head of the femur, this hand as the acetabulum, more coverage, less coverage. Now, if we think about a greater angle, so we've got more coverage, that's going to help with the stability of the joint. It's going to help to stabilize the hip, right? Because we've got more bony coverage, but it might also limit our range. So there's the trade-off between mobility and stability again. So with more coverage, we may have more stability, but less mobility, right? And if we look at these two pictures on the Mentimeter screen here, they're the same as the pictures in your lab book, but the pictures in your lab book are black and white, and you might be able to see it a little bit clearer on the screen in color. We're looking at the superior part of the acetabulum, and basically we're looking at how much this superior part of the acetabulum sticks out. So you can put like a pin on this screen on your computer and click on which of these pelvises or which of these coxal bones would have a greater center or a smaller center edge angle. Sorry, in your lab book you asked which one has a smaller center edge angle. So which one has less coverage on the head of the femur here? Yeah, good. So it is the one on the left. I'm sorry, you people probably did that before I clarified, but this one has more coverage, this one has less coverage. So this one has a greater angle, greater center edge angle. You can see the superior part of the acetabulum sticking out a lot there, whereas this one has a smaller center edge angle. Now with a smaller center edge angle, you might have less stability, meaning more prone or more predisposed to superior dislocation of the femur, right? Because there's less bony coverage, you might be more prone to superior dislocation, but you might be more mobile. You know who has a small center edge angle? You know what species has a very small angle there, or a very shallow hip socket, I should say, is Dalmatians. Does anyone have a Dalmatian here? Dalmatians are my favorite dogs. Don't tell Polly, but Dalmatians are my favorite dogs. They're rare beauties and you need to stop them in the street when you see them. Dalmatians have bad hips, so they've got very shallow hip joints and they often are predisposed to hip dislocations. So there's a dog with a shallow hip joint. Also, people from, I know I'm going to stuff this up, but is it like areas like Eastern Europe, so Ukraine, Russia, I think Slavic is the collective terminology for that descent. So Russian, Ukrainian, that type of area, those people of that heritage tend to have also very shallow hip joints. Have you seen the Russian dancing? It's like the, yeah, some of you know what I mean. I'm not going to demonstrate it. I'm sorry, this is not going to happen. You'll have to look up on YouTube, Russian dancing. I looked up, I was trying to find a video to show you guys, and I looked up on YouTube last night, Russian dancing, like traditional Russian dancing. I think it's called a specific thing, like I'm going to butcher the Kazowski kick or something like that, something similar to that. And anyway, I looked it up and the first thing come up was crazy Russian dancing. It has like 100 million views on YouTube. It's a very interesting video, but it's not quite what I was looking for. So I did not include this in the lab, but you can look it up for your own fun after. Yeah, I recommend. Okay, next one, acetabular anteversion angle. So essentially this is looking at the same thing, how much coverage the acetabulum provides the head of the femur, but now we're looking in the transverse plane. So you can see that picture is in the transverse plane. In your lab book, we've taken a cut and now we're looking down on the hip. So it's basically how much the acetabulum sticks out at the front, how much coverage there is over the head of the femur and how much this sticks out at the front here. Now, an important difference between this one and the previous is that a greater angle here actually means less coverage. So imagine a greater acetabular anteversion angle that would actually result in less coverage of the femur, right? So a greater angle would mean less coverage, would mean increased risk of anterior dislocation. So increased risk of femur coming forwards now. A smaller angle would mean more coverage. So over the page, you're asked to circle the one that represents a greater angle. So remember, a greater angle means less coverage. So which one of these two pelvises do you think has less coverage at the anterior part of the acetabulum? You can put your little pin dot on there. We're not too sure about this one. So something that I would look at is if there's less coverage, you're going to be able to see more of the socket, right? So have a think about that. Now, which one of these can you see more of the socket in? Yeah, a couple more people voting. You're right, it is the left one. So what I'm looking at is this right here. See, there's not much coverage. Can you guys see my mouse? Do a thumbs up if you can see my mouse. Yeah, so there's not much coverage here at the anterior part of the acetabulum. I can see the whole socket behind it, right? Whereas in this one, there's quite a bit of coverage. I can't even see the socket behind it. So this one would have a greater angle, meaning less coverage, meaning greater risk of anterior dislocation of the femur. So here's a picture of a hip dislocation. This one is a superior hip dislocation. Potentially, this person had less coverage over the top of the femur, so that would be related to our center edge angle. So potentially this person had a smaller center edge angle or less coverage over the top of the femur. I don't know, I'm just making that up. I literally just found this picture on Google, so I don't know the story behind this one, but yeah, so here would be an example of superior dislocation. I want to ask you guys, you can vote here, what do you think is the most common cause of hip dislocations out of these four options? Okay. A few different answers here. Most people saying falls, 1 sporting injury, 3 people on car crash. Now, you might be surprised to find out that the most common cause of hip dislocation is actually car crashes, right? It's very interesting. But what happens is when you're in your car, you're driving along, right? Your knee is in line with the dashboard. So if you run into someone head first, say you run up the back of someone, your knee's in line with the dashboard, that dashboard gets pushed back onto your knees, your femur goes from here nice and happy to your dashboard, boom, there it goes out the back, pops out the back. That's the most common cause of hip dislocation, and it is not pretty at all. Here is an x-ray of someone after a car crash dislocation. Absolutely horrendous. And if you've been in the car and you put your feet up on the dashboard and your mum gets angry at you and tells you put your feet down, that you can't have your feet up on the dashboard, this is actually potentially why this person, I do know the story behind this x-ray, and this person did have their feet up on the dashboard when they had a they run up the back of someone and the dashboard obviously came forwards and pushed the legs out backwards. So not pretty, but that's the most common cause of hip dislocation. Falls, like you guys said, is the most common cause of hip fracture. So fracture is different. Hip fracture normally occurs in older people. For those of you doing health and lifespan, you would know hip fracture, it's not good. About 50% of people, I think, is also when they fracture their hip, they never leave hospital, right? It causes that catastrophic sort of really bad, really bad. And because it's older people who are generally doing it, that's why they fracture their hip. It never fully recovers. It doesn't have a good blood supply coming to this part of the femur. So when you fracture your hip, it's normally on the neck of the femur. That's where the fracture occurs, on the neck. So it's not good either. All right, let's talk about the next two angles. So the next two are to do with the alignment of the femur. So the first one is the angle of inclination. And this is basically the angle between the neck of the femur and the shaft of the femur. So what's the angle between the neck and the shaft? Normally it's 125 degrees. So Normal angle would be 125 degrees. If we have a smaller angle, so perhaps the head of the femur points more to like a right angle, so a smaller angle, this is called coxa vara. I remember it because vara has got an R in it, R for right angle. Whilst it doesn't have to be at 90 degrees, it's just closer to a right angle, right? And then coxa valga, L for long, is when it's greater than 120 and we've got more of a vertical alignment between those, the neck and the shaft. So normally these two conditions are congenital, like you're born with it. Sometimes we see coxa vara where it ends up like a right angle in people with a vitamin D deficiency. I think it's called rickets or something like that. I might be wrong, but vitamin D deficiency, I think it's called rickets disease or Rockets disease, something like that. And when you are really deficient in vitamin D, it can actually make the bones more malleable, more soft. So you've got the weight of your body going down through this femur, and eventually that sort of causes the neck of the femur to sort of come downwards because the bones are sort of softer and more malleable with this vitamin D deficiency. So that's not good. And then for coxa valga, again, normally is congenital, can be caused by like things like if you have a fracture at your hip and when they repair it, you can end up with some malalignment. So normally like trauma, things like that. We do see it an increased prevalence of coxa valga in people with cerebral palsy as well, which is interesting. I'm not sure exactly what the mechanism is behind that, why people with cerebral palsy have this coxa valga. All right, so you can choose the picture that represents coxa vara in these, out of these two. Which one do you reckon it is? Yeah, it's the one that looks more like a right angle, exactly. Okay, awesome. And then we have the torsion angle. Now, we've heard that word torsion before, right? That rings a bell. We heard that word torsion back when we were looking like in week 2 when we did bone forces and bone loading. So torsion angle back then meant twisting, right? And that's pretty much exactly what we're talking about here as well. The torsion angle is how much twist there is in the femur. So the condyles of the femur, if we drew a line through them, are not at the same orientation as the neck of the femur. You can see clearly in these pictures here that the condyles are straight, right? But this picture here looks like as though someone's taken it and twisted the neck to point more forwards, right? And then in the other picture here, it's almost as though the neck of the femur is in the same orientation of the condyles. So they've taken the femur and they've twisted it backwards so that they're in the same alignment. So it's actually normal for our neck and our head of the femur to point slightly forwards at around 15 degrees. Excessively pointing forwards is called excessive anteversion. So if I took this femur and I twisted it so the head was pointing more forwards, that would be excessive anteversion. On the other side, if I took this femur and I twisted it so it was pointing backwards, that would be called retroversion.
Sorry, is that what causes pigeon toe?
It is, exactly. It is, yeah. So which one of those do you think would have the pigeon toe, the anteversion or the retroversion?
The anti.
Yes, you're right, it is. So when we have these conditions, if we have anteversion, so the femur's pointing too far forwards, your body doesn't like that. Your body's going to want to correct it. So if your femur's pointing too far forwards, your whole limb is going to internally rotate to put this back in a nice position. So by internally rotating, you're then going to end up with a pigeon toe with your toes pointing inwards, right? And the same thing happens for retroversion. So if the femur is pointing back, you're going to want to bring it back to its normal position. And to do that, your limb is going to rotate laterally and you're going to end up with your feet pointing out lateral as you walk, so like a duck walk. I have my feet point out laterally when I walk, and normally when we're in class I tell everyone that I don't know if I've got retroverted hips, but my feet do point out laterally, so potentially I do. But normally when we're face to face, and I tell everyone, I get self-conscious afterwards because I can see everyone in class like looking to see let's Clem's feet, like they're pointing outwards. But now we're on Zoom, you guys can't see, so sucked in. I shouldn't have told you. I probably shouldn't have told you. Anyway, so they can affect the way that our limb and our feet moves, and that can have a big effect also on injury as well, because you think about if you're rotating your limb, that's going to help the hip, that's going to have an effect at the knee and then at the ankle, and that's going to really increase the load. So you can see another picture here. This is if we had anteversion. So if the femur was pointing too far forwards, to correct that, you're going to rotate the limb inwards to make it fit nicely into the acetabulum, and that's going to cause that pigeon toeing or in toeing type position. Babies are born with anteversion, so if you've ever had some contact with a baby, you would notice that their hips are kind of funny. They're kind of like all squidgy and like really easy to sort of move around, and their toes sort of fall inwards all the time, and that's because generally you're born with this excessive anteversion that just corrects over time. All right.
Sorry, just quickly, in the question we've been given in the lab book, question 4 for that, which one is the which one are we supposed to circle with the torsion of less than 30 or greater than 30, sorry?
Yeah, so greater than 30, you guys put your pin on which one we're thinking here, which one of these images would be greater than 30. So yeah, it would be this one here, Holly. So greater torsion angle means there's more twisting or more pointing forwards of that head of the femur. So this would be excessive anteversion. This one would be retroversion. Think like retro, that's like back in the day, right? Retroversion, femur points back. That's a good little link there. You can use that. So retroversion, retro head of the femur points backwards. It's not fully backwards, but it's just not as far forwards as this one, I guess.
Okay, thank you.
No worries. Okay, and this was a little cheat sheet of the angles that I made a couple years ago, so feel free to screenshot this. It might have more information than you guys require, but it's got all of the angles and the info. All right, so I'm going to move on from this screen now. If you want me to come back to it at the end, just let me know. But now we're going to talk about measuring range of motion at the hip. Now, I wanted to actually show you a demonstration of how to do this. It is a bit hard for me to do it live on the camera because I can only, the camera is only here, so it's a bit difficult for me to show you from a good angle. So the other day I did go with sticky tape and glue tack and put my phone on the wall and tried to film some demonstrations of how you would actually do this in class. Now, I didn't have a person, so I did have to put the skeleton on the massage table and yeah, pretend. Now, these videos, I don't know what was wrong with me yesterday. I had a screw loose or something, but I just watched them back in the previous class. And in this one in particular, I didn't realize, but I've started talking and then I realized 10 seconds in that I wanted to restart it. So you'll see a bit of a blooper here. I do a double start, but this is behind the scenes, I guess. So enjoy. This is measuring hip range of motion. Oh, I'll make sure you can. All right, so here we have our patient. Oh, he's got a broken toe. Let's fix that. All right, so here we have our patient. Now we're going to talk about measuring range of motion at the hip joint here. So to measure range of motion at the hip, normally you'd get the person to move through the action that we're interested in today. It is flexion and hyperextension of the hip joint. So I would ask, hello, could you please flex your hip joint for me? And then, this is what I'm talking about. All right, measuring range of motion at the hip. So again, we have our goniometers. I'm going to briefly show you how we would do this if we were in class with a real patient, or in my case, a real skeleton. It's not a real skeleton. Okay, so the first one is hip flexion. So to measure hip flexion, we're going to bring the limb up through flexion, and then we're going to use our goniometer to measure that angle. So you'll notice as I bring the hip up through flexion and extension, I'm keeping the knee joint bent. And that's for a reason. I want the knee joint to be bent, because have a think about it right now. Do you think if you were lying here on this table, you would be able to get more range in hip flexion with the knee joint bent, or with the knee joint straight? Right? And I think most of you will have the same answer, in that you will probably get more range if you keep the knee joint bent. And why is that? It's because you take the hamstrings out of the situation. So by bending the knee, I keep the hamstrings happy. I'm not stretching the hamstrings. So by bending the knee, the hamstrings aren't stretched, and then I'm not limited by the tightness in those hamstring muscles. So with the knee bent, the patient moves into flexion as far as they can without tilting the spine or without arching their back. And then we're going to use the goniometer to measure the angle. So the axis of the goniometer, or the center of the goniometer, needs to be at the greater trochanter. So the greater trochanter is that bony part sticking out on the femur. We can feel it on ourselves. It's the bony part sticking out at our thighs. So axis at the greater trochanter. The stationary arm is going to remain level with the bed, in line with the trunk and the greater trochanter. And then the moving arm is going to move with the limb and end up in line with the lateral condyle of the femur. So I'm going to try and do this. I only have two hands here. It makes it a bit hard, but you can imagine, here we are, happy in flexion. So line up the goniometer, axis at the greater trochanter, stationary arm in line with the bed, and then moving arm pointing up towards the lateral condyle of the femur. And what did we get there? 120 degrees. Well done. So the normal range being between 100 and 135 degrees of flexion. Hyperextension now. So for hyperextension, we need to flip him around. Oh, he doesn't like it. Oh, he's lost a nerve. Okay, so hyperextension. Same thing, the goniometer actually goes in the same position, but here we also want to make sure that the knee is bent, and we're going to lift the leg up behind us. So there's our hyperextension of the hip, normal ranging between 10 to 30 degrees of hyperextension. This guy, because he's got no ligaments, no muscles, no fat, no skin to block him, he can go all the way over in hyperextension, but that's just not going to be possible for you or I.
All right, so that was my little demo of range of motion. Now you guys know that you don't actually need to worry about having to do that this year, which is great, but I thought it would still be useful just to have some demonstration and see how it would normally be done. So hopefully you get something out of that. But for you guys, the take-home message is those normal ranges. So 100 to 135 for hip flexion, and then 10 to 30 for hip hyperextension. You can already see there the difference in the mobility between the hip and the glenohumeral joint, right? The glenohumeral joint flexion was like almost at 180. And then the glenohumeral joint hyperextension was like at 50 or something, right? So there's a lot more range at the glenohumeral joint, but it also means that it's a less stable joint at the shoulder. So there's hip range of motion. Now, again, I've done the same thing for our next little activity, which is measuring leg length. So to show you how to do that, I've pre-filmed that just to give you a good demonstration from a good angle where you can see what's going on. I was thinking about, I don't know, I wasn't, but I was gonna I was trying to figure out a way for us to measure this at home and do some practical activity today, but I just couldn't think of anything where you'd be able to measure it. I assume like not all of you have someone at home at the same time, not all of you have a measuring tape, so it just wasn't plausible. So again, I hope that you get something out of me showing you how to do this on the skeleton, but here's the way that we measure our leg lengths. All right, now I'm going to show you how to measure leg length. So leg length is measured in one of two ways. There's true leg length and there's apparent leg length. Now, true leg length does exactly what it says it does. It measures the true length of the leg. So from the top of the leg to the bottom of the leg, what is the length? Whereas the apparent leg length takes into account things like the tilt of the pelvis or pronation of the foot, things that affect the length of our legs but aren't actually to do with the real true length of the legs. Hope that makes sense. So to measure true leg length, let's do that one first. We take our measuring tape and we find the anterior superior iliac spine. So to find that on yourself, you're just feeling for those pointy parts that stick out at the front of your hip or the front of your coxal bone. So we're going to put our measuring tape on the anterior superior iliac spine and take it down to the medial malleolus, and I'm reading 35 centimeters there. 35 inches, not centimeters. That would be weird. All right. Actually, let's figure out what it is in centimeters, because doing it in inches is not going to help us. All right, there we go. Let's say 88 centimeters. That's a bit more useful to us. So 88 centimeters on the right leg, and then we're going to do the same on the left leg. So we take our measuring tape from the anterior superior iliac spine down to the medial malleolus, and again I'm reading 88 centimeters. So that tells me that this person has this exact same true leg length. Now let's have a look at the apparent leg length. So apparent leg length, we're not looking for the anterior superior iliac spine anymore, we're now looking for the belly button or the umbilicus. So this guy doesn't have an umbilicus, so I'm just going to place it right about here and measure down to the medial malleolus again, and I'm reading 100 centimeters. And I'm going to keep the measuring tape on the umbilicus and take it to the other side now. That's 98 centimeters. So what does that tell me? If I have the true leg lengths the exact same, so I know that these legs, the femur and the tibia, are the same length, but the apparent leg length, which does take into account other things, is different. So that may mean that this person has a tilt in their pelvis, so they bring one hip up to the side like that. So it seems that their legs are of different lengths, but that's actually not to do with the length of the leg at all, it's to do with the tilt of the pelvis. Or perhaps there's something going on at the other end of the extremity at the foot, and one of their feet is really flat, which makes one of their legs appear shorter than the other. So that's how I measure true and apparent leg length. Now, if you do this at home with a family member, it's actually normal to have about 1 to 1.5 centimeter difference between legs in both of those measurements. So about 90% of the population does have abnormal or different length legs, and that's not it's not considered abnormal, it's just considered the normal variation in the limb lengths, and you probably wouldn't even know unless you measured it. The other thing you want to be careful of if you do this at home is that using the measuring tape, there's a lot of error, so you need to be really careful about the person lying on the table, making sure that their back is nice and straight, that their pelvis is in the right position, that their legs are positioned correctly about 15 to 20 centimeters apart,
so that you can get an accurate reading. You also want to be careful of the belly button. Now, some people, their belly button or their umbilicus is not actually perfectly medial. Sometimes it goes out to the side, and that can affect the reading that you get. So always be aware of just human error in those measurements.
Okay, so that is leg length. If you can, I do it at home with someone who you know, your bubble buddy or someone who you're living with. It's actually a very interesting activity. You'd be surprised by how many of you have got differences in the measurements. I know I said it was 90%, but yeah, in class, I know last year that like literally everyone had differences, and they were saying, what's wrong with me? Is this bad? Like, I have really big differences. And I guess if they're massive, then potentially there's something going on there. But you've also got to take into account just measurement error, which is a massive thing with this type of an activity. So it's very interesting to do at home on your own, but important to remember those landmarks. That's what I want you guys to remember. What's the difference between true and apparent, and how to actually measure those. That's what your take home should be from that video. Okay, now we're going to start talking about the knee joint. So we know a little bit about the knee already. We know from structural anatomy that it is, well, the knee, I guess, let me stop sharing this actually. The knee is like we've seen in the shoulder and the elbow. We're talking about like complexes, and the shoulder is actually made up of 4 joints and the elbow is actually 3 joints. Similar thing is happening at the knee. So I guess we've got 2 real joints here that create this knee complex. The first one is the tibiofemoral joint, so what we'd classically think of as the knee. And then the other one, which is important not to forget about, is our little patellofemoral joint, right? A patellofemoral joint between the patella and the patellar surface of the femur. That's a plain joint, very important little joint here. We're going to talk more about this soon. But the tibiofemoral joint. Now, if you look online, sometimes you can find this being called a bicondyloid joint. Sometimes you can find it being called a hinge joint. Now, for us in the instructional last year, we went with bicondyloid because that's like a level deeper. If you look on more like a basic site, they might say it's a hinge. It's sort of like a strange type of hinge joint. So they're not wrong, but a bicondyloid joint is more specific to what's going on here. And remember, a condyloid is like an oval. So the knee is actually like 2 ovals sitting together, and you can see that clearly when you look at the condyles of the femur, how that might create 2 sort of condyles meeting together at this knee joint. So very important joint, our knees. We probably take them too much for granted because our knees are very important for us. We use them all the time when we walk around, stand up, sit down. If you have some degradation of the knee joint, you're going to know about it, and it's not comfortable because of just how much we use our knees day to day. So they're very important. I think it's the biggest joint in the body. It's got the most going on. So very important joint. Now, the knee is bicondyloid. So what does that mean for actions? Well, we know just off the top of our head that our knee flexes and extends. That's its main action, right? And flexion and extension occurs in which plane? Out of transverse, frontal, sagittal. Well, flexion and extension actually occurs in the sagittal plane. So sagittal plane running down you, flexion and extension goes up and down that plane. So that's where most of our actions occur. The knee joint though, it also does a bit of abduction and adduction, right? See, abduction and adduction, side to side. Now, it's not supposed to do this. This is not like an action of the knee. Like if I told you right now, abduct your knee joint, you couldn't do it, right? But because of these long bones, because the femur is so long, the tibia is so long, when you put force on them, there's a lot of translation between those 2 bones. Because of those long levers, it means there's going to be lots of movement between that joint. So it does abduct and adduct a little bit, but we've got these 2 ligaments on the side here that help to limit that movement. So we know that the tibia is medial side of the leg. We know that the fibula is lateral side of the leg. So this ligament here is the medial collateral ligament. And then this ligament on the tibia side, on the fibula side, sorry, is the lateral collateral ligament. So medial collateral, in functional, we might have also called this the tibia collateral.
And then the lateral collateral, you might have also called that the fibular collateral ligament. Now, those two ligaments help to prevent that adduction, abduction. And adduction and abduction occurs in which plane? The frontal plane, right? So frontal plane, adduction, abduction. And then the last action that does occur at the hip joint is rotation. So as we flex and extend our hip, knee, not the hip joint anymore. So as we flex and extend our knee, there is some rotation that happens at the knee joint. And this rotation is actually very important and helps with the locking in of our knee joint. So if I told you to lock your knee joints right now, what are you going to do? You're probably going to extend your knee outwards until it's straight and it feels like it's locked in, right? We spoke about it a little bit at the elbow, about the locking in of that olecranon process and the olecranon fossa. So it's just like, think about the position that your knee is the strongest in, probably your knee straight out, right? Locked together, bones stacked. We're going to talk about that in a second. Firstly, I want to talk about some range of motion at the knee. Again, here's my little video from yesterday. I think I needed a coffee or something before. I probably needed one less coffee before filming these. All right, knee range of motion.
All right, guys, let's talk about the actions at the knee. So we know that the main actions of our knee are flexion and extension occurring in the sagittal plane. Now, as I flex my knee, I have about 155 degrees of range here. I could have 190, but really the range at the knee joint is limited by the fat and the muscle that lies in our posterior thigh and in the calf area. So if you have more muscle, you may have a greater limitation in that range. So if you have more muscle or fat, you might have less range of motion during knee flexion. Whereas if you have more muscle or if you have less muscle or less fat, you might have an increased or a greater range during knee flexion. Now, knee extension is another interesting one. Now, as we extend our knee, we know that our knee's out straight. So you'd think that knee extension would be 0 degrees, right? Because we can't go any further than straight, or can we? So let's jump up here. My legs are straight. Now in this position, if I contract my quadriceps hard, I'm going to be doing this leg right here. I didn't check underneath my shoes beforehand, so let's hope they are all clean. Now, I contract my quadricep and look at what happens at my foot. See, the foot rises off the table? So by contracting the quadricep, I can get a little bit of extension at the knee joint, or hyperextension this would be at the knee. So I can get around 3 degrees of hyperextension at the knee. So that is the normal range of motion there. So it's not actually 0, it can go a little bit past neutral. Now, the other thing I want to talk about at the knee joint is something called laxity. Now, laxity refers to the looseness of the ligaments, whether it's surrounding the knee, the shoulder, the elbow. Laxity means looseness of the ligaments. So as I flex and extend my knee backwards and forwards, the ligaments are getting tighter and looser in different positions. Now, at about 30 to 40 degrees of knee flexion, so if this is 90 degrees of knee flexion, 30 to 40 degrees would be right about here. The ligaments of my knee are at their loosest. That means that there's no stability, or not much. It's taking away one of the main key factors for the stability of the knee joint, because the ligaments aren't tight and they're loose right here. And you can see just with me pressing with one finger just how much my tibia is translating on that femur at the knee. So if someone walked past and bumped me right now, my knee is in a very vulnerable position for injury, because those ligaments are so loose surrounding it here. All right, so that should have sort of helped to answer those next couple questions in your lab book to do with the range of motion at the knee and laxity. I just wanted you guys to really be able to see me doing that slight bit of hyperextension at the knee. That's why I pre-filmed that one, because I think that's an important thing to be able to see. You might know someone who has knees that look like this, right? Very hyperextended here. Someone like this has just got more range in that position, and when they sort of stand or relax on their leg, it ends up looking a bit like that. So that would be like, well, like 20 degrees of hyperextension happening there when normally it's about 3. So some people are just anatomically different. Another thing with knee hyperextension, who wants to see a knee hyperextension injury? Damn it. Damn it. Oh. Okay. This is a good one. You might have seen this before. It does come with a warning. So if you have a weak stomach, maybe look away now. But
an aerospace engineering major.
Such an impressive young lady.
Let's see how high she flies right here.
Yep. Ooh.
And I think she
all right, one more time.
Flies right here.
Yep. Ooh.
So you can see literally the tibia is behind the knee here, like it's gone backwards. So that's a knee hyperextension injury. Did I show you guys that in structural anatomy? No? I sort of try and find any excuse to show this video as possible. It's my favorite thing to do in class, to show bad injury videos. So anyway, if I didn't show this in structural, there's one more thing I want you to see. So I'm going to play it again. But listen to what the guy says. He's like, oh, I think she's landed a bit too hard on her ankle.
Let's see how high she flies right here.
Yep. Ooh.
And I think she may be hurt. It looked like that ankle came down very awkwardly, and she...
Yeah, so terrible injury. This is a career-ending injury. It's not good at all. Absolutely horrible. All right. So there's another example of knee hyperextension. Okay, I'm going to get you guys to label this picture in your lab book now, looking at the superior view of the tibia in the knee joint. So we can see the anterior cruciate ligament coming from the front of the tibia and the posterior cruciate ligament coming from the back as well. Then we can see our meniscus. So the medial part of the meniscus is much bigger than the lateral part. So the two sort of semicircles, the medial one is much bigger. And then underneath those semicircles of meniscus, we can see the articular cartilage that would be on the tibia. So we know that the articular cartilage, it's the hyaline cartilage that's on the ends of the long bones. And it's just, its more specific name is articular cartilage. Don't worry about writing like on medial tibial condyle, just write articular cartilage there. You don't need that much information. But the meniscus is very important for the load bearing within the knee. If we just think about how much force our knee is under day to day, just with the weight of our body, there's a lot of force going through that knee joint. So that meniscus is really, really important. It's made of fibrocartilage. And Lee spoke about the load bearing properties of cartilage in a previous lecture. So remember, cartilage has those viscoelastic properties, which means it helps with load bearing through the creep and the stress relaxation theories. Has anyone in here had their meniscus removed? No, I had someone last year, a student who had their meniscus removed from their knee. And a lot of people who get their meniscus removed, they tend to say, oh, I've had the cartilage removed from my knee. So you might have heard someone say that before, but it's not actually the cartilage, it's the meniscus that's being removed, which I guess is a type of cartilage, right? Often if you tear your meniscus, not often, but if you tear your meniscus, sometimes it can be so hard to repair and it can cause you so much pain that they end up just taking the meniscus out altogether.
as a way to fix it, right? It's commonly done. It was, you know, that one of the students last year has had the meniscus removed. The bad thing with it though is that within a couple of years of having the meniscus removed, it is like a guarantee that you will have early osteoarthritis of the knee joint. That's how much force is going through there. By taking out the meniscus, that articular cartilage is going to start rubbing together and going to start wearing down and degrading, and you will have early onset osteoarthritis. So it's not good to have that.
Why would you not like put something in its place?
Good question. I'm not sure. Perhaps they don't have the technology to replace something like a meniscus yet. But I have wondered what is the rationale behind this surgery, and normally it is to do with a torn meniscus that is not possible to repair, that's causing pain. So they remove it and then just deal with the osteoarthritis as that comes, I guess. But yeah, it seems barbaric, right? But there must be a reason that I'm not aware of as to why this would be a decision that's made, you know? All right. Now, over the page, we have a couple questions to do with the screw home mechanism. And I know I said I was going to talk about the rotation of the tibia of the knee joint again. And this is what we're talking about here. So we're coming back to that rotation of the knee joint. It's only slight. There's only a little bit. But that rotation of the knee joint helps with the locking in of the knee. So let me just see what's the next slide. Okay. Stop sharing now. So when you're standing straight and you extend your knee fully, there's a locking in mechanism of the knee, and the condyles of the tibia and the femur, they sort of lock in and they screw together. This is called the screw home mechanism. And what happens is that in end range of knee extension, the tibia rotates laterally on the femur. So I'll say that again. In end range knee extension, the tibia rotates laterally on the femur. Now, the reason that is because here we have our femur, right? We've got the head, so we know that this is medial, this is lateral. So medial here at the head. So if I go down, this is the medial condyle, this is the lateral condyle, right? You can see already that the medial condyle is much bigger. If I show you from the back, you can see clearly the medial condyle here is much bigger than the lateral condyle. So what happens as you extend your knee is that the tibia, so medial condyle is closest to you guys, the tibia actually gets to the end of the lateral condyle first. So the tibia gets to the end of the lateral condyle, then to finish off the knee extension, the tibia has to move on the medial condyle and it laterally rotates to do that. So because the medial condyle is bigger, the tibia reaches the end of the lateral condyle first, and then it has to laterally rotate around the medial condyle to lock in and finish off knee extension. So this is what we call the screw home mechanism. It's the lateral rotation of the tibia in end range extension due to the big size of the medial condyle of the femur. I know that's a bit of a mouthful, but that's what happens as you get to the end range of knee extension. If you want to do this, I'm really starting to get used to the working from home lifestyle. I literally don't have shoes on under here, so I'm putting my shoes on quickly because I am going to have to show you my legs. So screw home mechanism is a really cool way to see what it looks like. If you have a Sharpie or a pen and if you have your legs bare and ready to be drawn on, you can actually see how much your tibia laterally rotates as you move. So you can have a look at this. So here's my knee. The first landmark I want to find is the center of the patella. So to find the center of the patella, I can palpate the patella, I can feel it like that round bone, and then I want to put a dot right in the center of it. I know that might be a bit hard for you guys to see now, but I'm putting a dot right in the center of my patella. Then I'm finding my tibial tuberosity. So my knee is bent whilst I'm doing this. I'm finding the tibial tuberosity and I'm going to put a dot on that as well. So in the bent position, those two dots line up perfectly. It's pretty much a straight line between those two dots. I know that you probably can't see, but those two dots line up perfectly. Now, when I extend my knee outwards, because right at this end range of knee extension, right when I contract my quadriceps at the top of knee extension, the tibia rotates laterally, and now my tibial tuberosity is off to the side. So I could draw another dot on where my tibial tuberosity is now, and you can see it's gone off to the side. Let me see if I can have this. All right, we're going on cam mode. So you can see there's my knee. When it's straight, it lines up with the tibial tuberosity here. When I extend it, now my tibial tuberosity is there. So you can see the two dots. It's moved laterally through knee extension. So the tibial is rotated laterally. All right. That was fun. Okay. Now I want to talk to you guys about the patella. So we said that the knee complex is sort of a combination of the tibiofemoral joint and the patellofemoral joint. Let's have a look at the patella now. So we know the patella is sesamoid bone. Sesamoid bone is a bone within a tendon. So here it is here within a nice little tendon. And we know that the muscles that go into this tendon are our quadriceps muscles, right? So rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, all coming into this tendon. Then there's the patella, and then down into the tibial tuberosity, which is the insertion point of those muscles. Now, if you remember, like back in PDHPE or whenever you first started learning about the difference between tendons and ligaments, the first thing they teach you is that a tendon connects muscle to bone and a ligament connects bone to bone, right? You've all heard that before. So muscle to bone here, from the quadriceps to the patella, this section of the tendon is often called the quadriceps tendon. But then we get into this part here, where it's coming from the patella to the tibia. And often, because it's going from bone to bone, people call this the patella ligament. Now, that is not, it's okay to call it that, but it's not necessarily correct, because tendons and ligaments have different properties. They have different biology, right? This right here, even though it is going from bone to bone, has got the properties and the biology of a tendon. It's got the Golgi tendon organs. It looks like a tendon under a microscope. It doesn't look like a ligament. So whilst people refer to it as a ligament, I still like to call this the patella tendon. So actually this tendon has got two different names: quadriceps tendon at the top, from the quadriceps to the patella, and then patella tendon at the bottom, from the patella to the tibial tuberosity. Now, we spoke about the functions of the patella back in structural anatomy. So remember things like anterior protection was one of the functions. It plays an important role in shock absorption as well. And it also acts as a lever for the quadriceps. And Lee spoke about that a lot in the lecture for this week. So that leverage function. So three main functions of the patella. The patella is very important for movements of our leg. And when the patella doesn't move correctly in its little groove, this is often known as abnormal patella tracking, right? And it's caused by a few things. So firstly, you could have a torn meniscus, which results in changes in your biomechanics, and then the patella is like pulled one way or another because you're moving your leg differently. It can be caused by patellofemoral pain. So this isn't often a cause of pain for a lot of people. If you do a lot of running or a lot of sport that involves a lot of flexion extension at the knee, often the soft cartilage, the soft articular cartilage behind the patella can get inflamed and wear down as it rubs. So this is what's called patellofemoral pain, very common in females. And then it can also be caused by weaknesses in different muscles. So let's have a look at this picture. Now, I love looking at like pictures of like ridiculously muscly people and trying to identify all of the muscles. It's just a pastime of mine. So here we've got our quadriceps. We can see in this guy clearly, this is the vastus medialis coming down here, like sort of making a roof over the patella. We have the rectus femoris, that triangle shaped muscle, and you can see there its medial tendon coming down. And then we have the vastus lateralis on the side here. So often people have very strong lateral quadriceps and very weak vastus medialis. So that vastus medialis is often quite weak in a lot of people. And what that causes, if you've got strong lateral muscles and a weak medial muscle, that patella is going to get pulled out laterally, right? Because you've got those strong lateral muscles, you have that imbalance. So it's going to get pulled out laterally. And this is a common mechanism of patella dislocation. Has anyone in here dislocated their patella before? No one in here? We had someone in the last class. So patella dislocation almost always happens where the patella goes lateral, right? The patella moves laterally off its little groove, and it's not a nice dislocation. It's very, very unsettling, and often people who dislocate the patella, they always have the feeling like it's going to dislocate again, like it becomes very unstable, but it always goes out laterally. Almost never will you have a patella dislocation where it moves medially. So lateral dislocation is the common way. The guy who had the patella dislocation in the last class, he said he has already had multiple dislocations. So once you do it once, it tends to happen over and over and over again. It's not fun. So yeah, common cause of that is muscle imbalances and the patella being pulled out laterally. Another way that the patella gets pulled out laterally is through a wider Q angle. Now the Q angle was the next thing that we normally measure in class, because again, we aren't in class, which is making me very sad. We aren't really able to do this online. So I've done another video. Here I'm talking about the Q angle. So I'll explain a bit what that is and how to measure it here, but let's have a look at this video first of all. Hi everyone. So the next thing I want to go over is how to measure the Q angle. So the Q angle, to measure it, we need to find 3 landmarks. The first one is the center of the patella, so we can easily palpate and feel the patella, and we just want to find the midpoint of that, so we might draw a little dot onto the center of our patella. The next landmark we want is the tibial tuberosity, so the lumpy part on the front of our shin. And then we also need to palpate and find the anterior superior iliac spine. So those are the 3 important landmarks for measuring the Q angle. To do so, take the goniometer and place the axis in the center of the patella and the stationary arm in line with the tibial tuberosity. So I have a line going straight down from the center of the patella to the tibial tuberosity. And then I'm going to take this moving arm and I'm going to line that up with the anterior superior iliac spine. So that line would travel and meet that spot. So it is a bit of an estimation as to where you're placing this. Let's place it right about there. I think that's pretty accurate. So on my reading, I'm getting only 5 degrees. So sorry, that was a bit of a cliffhanger at the end there. My glue tack and sticky tape contraption did fail me towards the end, so I decided just to leave it at that. So sorry, I didn't actually explain what the Q angle was in that video, so let me first do that and then I'll talk more about the measuring. So the Q angle is essentially the angle between the pull of our quadriceps and our femur. So you can see here that the femur comes down on an angle, right? So it's not perfectly straight. It actually shoots inwards and down. Now our quadriceps, when they pull on the patella, they pull straight upwards. So we're interested in the angle between the pull of the quadriceps, which is generally straight up, and the angle of the femur. So how much the femur shoots outwards or inwards. So this is the Q angle. And generally, if we have wider hips, we're going to have a larger Q angle. So wider hips means that the femur is going to come down at more of an angle, meaning that the pull of the quadriceps is going to be way off the angle of the femur. So that's what the Q angle is. To measure it, we find those landmarks. Now, what I was saying in that video before there was the cliffhanger was that I was reading about 5 degrees on the skeleton, but obviously the skeleton is not perfectly life size. So generally in men, we find about 10 to 15 degrees is the norm. And in females, to allow for a bit of a wider hip, 10 to 19 degrees is the norm. So the greater our Q angle, the more lateral pull there's going to be on the patella, right? And that is going to increase the risk of dislocation or predispose, patella or knee injuries, right? Because there's a greater pull on that. So essentially, you could also think of it as the angle between the patella tendon and the quadriceps tendon. That's another good way of thinking of it. The angle between the patella tendon, which is vertical, and the quadriceps tendon, which can be pulled out lateral depending on how wide or narrow the hips are. Something I want to ask you guys is if we go back to this image. All right, let's look at this picture here. For the one on the left, I want you to do number 1. And for the picture on the right, I want you to do number 2. So the first picture on the left is number 1, second picture on the right is number 2. Which one of those do you think is the female pelvis? Do you think it's number 1 or number 2? Actually, let's do it in a way where everyone can vote, even if you're not able to have your camera on. So give me the thumbs up sign if you think this is the female pelvis. Okay, only a couple. Give me a thumbs up if you think this is the female pelvis. Okay, a few more. So this is the main guess, all right? So let's go back now. Remember what you guessed? Let's go back. Oh, here we go. Okay, so this isn't in your lab book. This is just some extra information that you might find interesting. I find it interesting, but this is how to tell the difference between a male versus a female pelvis. So there's 3 things to look for. The first one is the pelvic inlet. So how much space there is within the pelvis. In a female, it's going to be much larger because you got to, fit a baby through there. So pelvic inlet is much larger in females. The next thing you want to look for is the pubic arch. This is the first thing that I look for. When I see a pelvis, I look at the pubic arch. I think it's the easiest way to tell male versus female pelvis. For a man, it's going to be a small angle here, about 60 degrees. For a woman, it's much wider at the pubic arch. And then the third thing that you can look for is the sacrum. So in a male, the sacrum is going to be much more rounded and tuck underneath, whereas in a female, the sacrum is almost straight. So in this part here, you can see that the sacrum is rounded and tucks under. You can assume that this is a male pelvis, right? Whereas a female pelvis, the sacrum is much more straight. So like I said, I like to look at the pubic arch as the first point. So let's go back to that picture now where you guys voted. All right, have a look again. Do the thumbs up, react if you think now this is the female pelvis. This one? All right, still a few people saying that it's this one. It's actually this one here. You can see the pubic arch is much wider. See, that's the easiest place to look. Some of you might have been looking at the inlet. It's a bit harder to tell with that. So I look straight at the pubic arch, which is the angle here. You can see there's a much smaller angle in this one than there is in this example here. So there you go. Obviously, this is not a good science, but easy things to look out for if you're interested in that. Okay, so we're not gonna do a complex movement analysis today. If you haven't already, make sure you go and watch the video from last week about the complex movement analysis and how to do that. But we're going to do our first one together when we come back from Stuvek next week. So have a great break. Thank you guys for turning your cameras on, for those of you who managed to. It's very nice for me to actually feel like I'm talking to people, so I appreciate it. And I also understand that those of you without the cameras on, you know, sometimes there's things that limit you from doing that. So don't think I'm saying that you guys are naughty, which you're not at all. All right, so yep, enjoy your week off. I'll see you guys in a fortnight. Have a great day.
Thank you.
Thank you.
Thank
so
you.
much.
Thank you.
Clem,
I've just got a quick question about health and lifespan development.
Yeah.
If our interviewee wants to remain anonymous, is that okay?
Yeah.
Yeah.
Okay. Thank you.
No worries.
Clem, I just have a quick question. I don't know if I just to make sure. Something, I think it was the angle for knee flexion. Is that what it's called? Yeah, what was the number for that one?
155.
55. Okay, I had 165.
I might have said it a bit funny in those videos.
And that's the one that, like you said, about the more muscle or fat, that one.
Yeah.
Okay. And my second question, really quickly, for health and lifespan development,
Mhm.
can the interview, like, do I have to be like I'm consistently asking them questions back and forth, or can I just get them to like read out or get them to answer like one whole thing in a spiel?
Yeah, it's totally up to you. That's fine as well. Another thing that people do, which I find works well, is you don't actually ask them a question at all. You might be talking about a topic and then there's an excerpt from the interviewer, in the interviewee. Like, you don't necessarily have to be like, so please tell me about this. Like, you might be talking about a topic and then that cuts to them talking about it. But yeah, it doesn't have to be continuous at all. It doesn't have to be throughout. It might just be one part of it as well. That's fine.
Yeah, because obviously it's like hard to meet up with them. So I just like sent them the questions and they're like reading it off, and I didn't want it to be like they're reading a piece of paper, but like, okay, that makes sense.
Don't worry. I'm going to be very lenient on that stuff considering the circumstances. So don't worry.
Okay. All right. All good. Thank you.
Welcome. Daniel, how are you going?
I'm all right. How are you?
Yeah.
I missed two questions.
Yeah.
In station 5, with the surface motion of the knee, I missed what plane does the largest movement occur?
Sagittal. That's
Okay.
flexion and extension. Sagittal plane.
Thank you. And for station 6, describe the load-bearing properties of the meniscus.
That's actually from the lecture. So it's to do with like creep and stress relaxation. So head back to biomechanics of cartilage in lecture.
Okay. No worries.
Awesome.
Thank you.
All right, bye.